Hi, and welcome to today's webcast, Avoiding Opioid Dangers in Seniors. I'm Lois Bowers, Senior Editor of McKnight's Senior Living, and I'll be your moderator. We can't go online, watch television, or open a newspaper today without seeing or hearing something about the opioid epidemic in this country. Many times the stories are about young people, but unfortunately, older adults have been affected by this epidemic as well. Maybe you've seen it up close. But regardless, it's important to realize that residents in independent living and assisted living communities can be in danger of developing an opioid addiction due to their increased risk of falls and other injuries. So senior living operators need to develop plans to mitigate that risk. We're pleased to have Todd King, Director of Clinical Services at Omnicare, with us today to describe the epidemic, the use of analgesics in older adults, and common risks of opioids in this population. We'll hear from Todd in a few minutes, but first we have some housekeeping matters to take care of. If you think you're experiencing audio difficulties with this broadcast, please first check the volume on your computer. We found that this is the most common cause of hearing issues with presentations like this one. The sound should come from your computer speakers. If the volume control doesn't appear to be the issue, then please click the Help button at the upper right of the player for assistance. Please keep only one browser window open on your computer to prevent echo. Also, we will have time for questions and answers at the end of today's presentation. If you have any questions about the information presented, please feel free to send them directly to us at any time during this hour by clicking the button and typing them. This educational offering has been reviewed by the National Continuing Education Review Service of the National Association of Long-Term Care Administrator Boards. It has been approved for 1 clock hour. The CE credit is available only for those who have registered and are listening live. If you'd like to earn a certificate, you must register for the webinar at www.mcknightseniorliving.com/December5webinar. Log on and listen on a computer that is separate from those of others who wish to receive credit. Please note that you must stay tuned to this event in its entirety during its original broadcast to receive a certificate. A certificate will be emailed to all eligible attendees at the conclusion of this webinar. Please allow up to 24 hours for it to arrive. We'd also like to note that this program is made possible by support from Omnicare, a CVS Health company. Please visit the company website at www.omnicare.com. But remember, do not interrupt this webcast presentation if you would like to earn the CE credit. Finally, this session will be archived and available on demand shortly after this live broadcast. You can access the webcast again at no cost, and others can experience it for the first time again at no cost by simply going to the registration page to enter this studio. The web address again is mcknightseniorliving.com/December5webinar. As I mentioned, however, accrediting bodies dictate that CE credit may be given only for attendees at this live broadcast. Now I'd like to tell you a little bit more about today's featured speaker. As I mentioned, Todd King is Director of Clinical Services at Omnicare. There, he is responsible for overseeing clinical services for the Southeast and Northeast, including managing the consultant pharmacist and clinical managers for the region, implementing clinical programs, managing facility formulary, and providing education to customers and staff members. Todd is a certified geriatric pharmacist and has worked in the long-term care industry for 25 years. He holds a Doctor of Pharmacy from Campbell University School of Pharmacy and completed a residency in geriatrics and long-term care in Durham, North Carolina. I've taken a peek at his slides and can tell you that he has a lot of helpful information to share. So with that, I'm going to turn things over to Todd so he can begin his presentation. Todd?
Thanks, Lois. I appreciate the introduction, and thank everybody for taking time today to join the webinar. As Lois mentioned at the beginning, the opioid crisis is something that nobody can turn their TV on for a day and not see some of the tragedy out there that's happening around the use of opioid narcotic medications. And, you know, it's estimated that about 90 Americans die every day from overdosing on opioids, and the healthcare cost right now is estimated at about $78.5 billion annually in healthcare costs, addiction treatment, and other types of items that impact the healthcare system overall. And I think it's an area where, as Lois mentioned, most of the time we think of younger adults when we think about opioid addiction and opioid overdose. But because our senior population is often very sensitive to the side effects of these medications, we thought it was a good opportunity to kind of talk a little bit about some of the situations that can occur with the treatment of pain in our seniors who live specifically in independent and assisted living type of facilities. You know, the history here kind of goes back to the mid-1990s when the opioid industry pretty much confirmed to the healthcare systems that opioids had a low potential for addiction. And those of us who have been in the medical world for quite some time kind of felt that that was somewhat of a stretch on some of the clinical things that we've seen out there in the real world setting. So that was kind of a perception that occurred in the 90s, which led to a lot of overprescribing of these medications. And so lots of times there's opportunities and situations where we may have a senior who has been taking these medications for quite some time for a chronic pain condition. And as these medications are dosage changed or doses increased or decreased, our population is naturally at higher risk for those adverse events. And lots of times we're not, as we'll go through in the presentation, we're not talking about an overdose or something that you might see in the news or something like that. We're looking more at problematic side effects that can increase the risk for falls, that can increase the risk for cognitive impairment, things that ultimately could wind one of our seniors up in a hospital setting or in after an event such as a fall in a long-term care facility outside of their senior living environment. So I'm going to go through the slides today and just kind of talk to you a little bit about some of the statistics. We'll talk a little bit about some of the common medications used to treat pain in the elderly. We'll talk a little bit about non-pharmacological treatments, which I do think personally have a valid place in therapy when dealing with chronic pain conditions in our elderly population, and then also just discuss some of the opportunities that we have around safe prescribing of narcotic analgesics. So on our first slide, I kind of already talked a little bit about this, but I think it's important to reiterate why this topic. And there's about 76.5 million Americans that are more than 20 years reporting pain in any type that persisted more than 24 hours. In older Americans, older Americans are the most undertreated for pain. And I think everybody can kind of understand that because our population, as the slide says, is the least likely population to actually report chronic pain or pain. You'll see also in the slide that those adults aged 45 to 64 were the most likely to report pain, and a lot of people think that that's probably because that's the time frame when people start developing arthritis. They may have their first major medical event, something like that, whereas our folks who are over the age of 65 in their 70s or in an independent living facility or assisted living facility choose to kind of deal with their pain in a lot of situations. So we actually, if you think about that, have a couple dilemmas. Our dilemmas are making sure that we as healthcare professionals appropriately assess and identify pain, so it's not undertreated, but then also when we do choose to treat the pain that we use the safest medication possible at the least effective dose. Other statistics here, 45 to 80% of long-term care residents experience pain on a daily basis. However, 25% of those folks do not receive an analgesic or non-pharmacological treatment. This is an area that I do think that we can all improve on and better provide our seniors with an opportunity for a higher quality of life. And then naturally, some of the opioid issues that we'll talk about do affect the elderly population. As I mentioned earlier, they're not quite the same as it is in a younger person when we deal with addiction and overdose. We're going to talk more about the management of specific side effects and potential problems there. The next slide I think is is an important slide because it does show that people who have chronic pain, specifically in the older population, do have an impact on quality of life. And as you look at these statistics here about those patients who are chronic pain sufferers, lots of times over 70% they feel depressed. A lot of them have trouble concentrating because of their pain. About 3/4 of them have their energy levels impacted, and then close to 90% have the inability to sleep well. And as everybody knows, is in a geriatric person or someone who is at advanced age, the more times we see these somatic chronic complaints, the more time there's likely a medication. And anytime you add an additional medication to an already complicated medication profile, it does put that resident at risk. So let's look at a couple definitions of pain, and I think these go. I like the way these kind of flow in the slide because one is very complex, and then the last one is probably the most simple and probably has the most impact to me when I read it as a clinician. But the American Pain Society says that pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. While it's unquestionably a sensation in parts of the body, it's always unpleasant and therefore an emotional experience. The Centers for Medicare and Medicaid Services say, CMS, says that pain is an unpleasant sensory and emotional experience that can be acute, recurrent, or persistent. And then a nurse, Ms. McCaffrey, in 1968, defined pain as whatever the patient says it is. And I think that's a pretty impactful comment because to me, that means that our patients do have to process their pain. They're the ones who are going to assess it the best and give us the information on where the pain's occurring, what types of things cause it, and how it can be managed appropriately. So I like all three of these definitions, albeit they're all very different. I think it's good to kind of take into account different definitions when you talk about pain because it is a personal experience and people tolerate pain at different levels. That's why in a lot of cases our geriatric populations are the most often underreporting their pain because lots of times they are tolerating that pain because it's been there for a long period of time. So next slide just talks on the classification of pain, chronic versus acute pain. And I think this is a nice slide just because it kind of talks about some of the differences that can occur. And I think those of you who have dealt with pain personally understand the difference between acute and chronic. Acute pain usually happens from an injury, a tissue injury, and resolves over a period of time. The intensity is variable. There's associated anxiety, especially if it is an accident or some type of situation that happens in an urgent or an acute situation. The pain behaviors may be rubbing. They may be more prominent when the pain is severe. And then the associated features would be sympathetic hyperactivity, increase in heart rate, sweating, increase in blood pressure, those types of things. I think a lot of times you got those of us that are younger when we had incidences where we had to go to a doctor to look at a sprained ankle or a knee or something like that happened in an acute situation. Lots of times you've noticed that the blood pressure of the person was up, which was abnormal. They were sweating. They're often tachycardic. So those are responses to acute pain, of which most of the pain in our elderly population is chronic, secondary to chronic inflammation conditions like arthritis. They do experience acute pain also, as everyone knows. But chronic pain is, the timing is remote. It often lasts longer than 6 months or continuous after the cause of the pain is resolved. Intensity is variable. Some of the problems that can happen with chronic pain, and we've touched on this already in the previous 2 slides, was irritability or depression is common with people who have chronic pain. And then associated behaviors may be not being able to give a specific pain behavior, but being able to try to compensate for that pain. And then associated features can be things such as fatigue, anorexia, weight loss, insomnia, as we mentioned in the previous slide, that almost 90% of the folks who have chronic pain do have difficulty sleeping. So this slide just kind of differentiates between chronic and acute. I think it's important when we deal with our elderly population and those who are living specifically in independent living and senior living housing, that when these situations occur, especially from an acute standpoint, they're treated acutely. In a chronic situation, they're treated chronically. So from a clinical standpoint, and I just put this in here because I think it's a nice reminder that we really do need to properly assess pain to make sure that we're treating it correctly, because if the pain's not assessed correctly, it's really hard for us to choose a medication. And lots of times what happens to our elderly folks, they may get one medication to treat one type of pain and another medication to treat another type of pain, whereas we could possibly use a different medication to treat those two specific areas. So I like the PQRSTU pain assessment mnemonic, and it kind of goes through some of the specific situations where you can talk to a resident and kind of get an idea of where that pain is. Now, people use all different kinds of pain assessment tools. I think from my perspective and from what you see in the literature, it's important to use a tool that, one, you're comfortable with administering. So in an assisted living environment or a senior living environment, is making sure that it's something that can be easily communicated, that it's something that can be understood by the resident when they're being assessed or evaluated. But I think as caregivers, that assessment is very important. So if I'm a clinician in an assisted living facility or seeing somebody on a home care visit in an independent living area, making sure if they are being treated for pain, look and see if there has been an assessment to see what type of pain we're dealing with, especially to make sure that when we look at the medication. So the P is precipitating factors. One of the things that's key about evaluating pain is figuring out what makes it hurt. I mean, that's the key thing. What makes your pain better, what makes it worse, how movement affects it, how hygiene or care affect it. And then so making sure that we're able to cause and look at those precipitating factors, because lots of times the removal of those or the modification of those precipitating factors can be one of the key resolutions to resolving that pain, which may not be a medication. The quality of the pain, please describe that pain for you. Is it sharp? Is it burning? Is it aching? That type of thing. Radiation or pattern, does the pain move from one place to another, or does it stay in one place all the time? Folks who have arthritis, and most of us who've dealt with our senior population, they'll tell you that arthritis moves. It's in different parts of their body day after day, and that's an assessment that needs to be done to make sure that we're using a medication that effectively treats the body systemically instead of treating one specific area. The severity or the site, this is probably the key factor of making sure that we've got the right assessment of pain, is knowing what the intensity is. And as our nurse friend talked about earlier when she defined pain, it is whatever the patient says it is. So as long as the resident is cognitively intact, lots of times the 0 to 10 scale does work very well. So that is an opportunity to see how that pain is as it radiates or moves through the body. Temporal nature, is your pain constant or intermittent? That's a simple question. As I mentioned earlier, a lot of our elderly folks are going to have a constant type of pain. And then you. What are your pain management goals, including intensity, quality of life, and activity level? This is a nice assessment to where we get the resident involved in their care situation, making sure that we know their goals and making sure that we can modify and help work towards those goals for the resident to make sure that they're using medication appropriately and avoiding potential side effects and adverse reactions. The next slide just looks at some pain assessment scales. These are just some examples of some things that I put in there. I think we've all seen the Long-Baker faces of pain rating at the bottom, the smiley faces. This is a tool that can actually be used for residents who might have mild cognitive impairment, because that type of recognition with dementia does not decrease over in the initial stages of dementia. So there is an opportunity to use these types of tools. And as I mentioned, there's other here that talks about description of the pain, numeric pain rating scales, and then the visual analog scale. So I think it's important to just pick a tool that is liked by the patient, liked by the clinician, and can be used to set goals to looking at appropriate pain treatment. So I think these are key tools that we can utilize, and I think I'm going down this path because I want to make sure that, lots of times we see one of our residents leave a facility, go to a doctor's office, and they come back with a new medication that's for pain, and we want to make sure that the facility and the staff members who are working with these residents understand what the goal is for that pain treatment. It's not just a prescription. There's lots of other things that go along for appropriate pain management to, once again, our goal of avoiding those side effects and especially side effects and issues with opioids. So we're going to shift gears now for the next few minutes and talk a little bit about treating pain, and then we'll go through some of the specific classes of medications real briefly to just touch on a couple situations where I think we can take away some clinical pearls today to better evaluate our residents who are being treated chronically for pain management. I mentioned earlier that non-pharmacological treatment options are really important in pain therapy, and I think as you look at the balloons here on this slide, there's a lot of opportunity for us to utilize these tools to make sure that we are using non-pharmacological interventions, because all the things that are on this slide have been shown to be effective and be useful in treating pain from a non-pharmacological standpoint. So physical therapy and non-physical therapy is kind of how I broke them out. I'm not going to go through every one of these, but I think these are good examples of things that are out there in the community and out there in the field. Hot and cold treatments, massage, magnets, chiropractic therapy, acupuncture, TENS devices. Exercise is very important for our arthritic patients to make sure that those joints move and do the things that they need to do. Proper positioning. Those of you who, positioning is a key item. Those of you who know you go to a new bed or sleep in a hotel room and maybe you're not on your own bed and you position yourself the same way you would in your bed, but you're in a different area and you're not positioned according to that bed. You wake up in the morning with a little bit of a back pain or that type of thing. Positioning is so important in these folks because of their chronic conditions, et cetera. And then non-physical therapy, just educating our residents on their pain, counseling, support groups, alternative medicine, aromatherapy, music, relaxation techniques, all of these types of non-pharmacological, non-physical therapy interventions are getting a lot of use out there, especially in the assisted living and senior living environment where these residents are more apt to be able to participate in their care and participate in physical therapy and some of these non-physical therapy activities to make sure that they're getting the most out of those. So I really do see this as an opportunity for us in the senior living population, because of their pain and the situations they have with their pain, to reduce medications and therefore reduce some of the adverse events and potential adverse events that we're going to talk about in the next few slides. So let's talk about some medication here real quickly, and just I'm going to go through these slides and just kind of give you my take on these specific medications and remembering that a lot of the drugs that we'll touch on are going to be medications that can be used for chronic conditions or acute conditions, as some of them are very common in the elderly population. I would also like to caveat that when we're dealing with the assisted living and senior living, independent living environment, many of these medications are available over the counter and do not therefore require a prescription. So it's one of the situations where we do see our elderly patients and seniors sometimes purchasing these medications on their own, and that can lead to problems taking multiple medications from the same class. Naturally, we're focusing on opioids today, but which all do require a prescription, but I think it's important to remember that when we see folks out there in the community taking opioids, there's a good possibility that they're taking other medications for their pain that they've purchased at a local pharmacy or purchased from their grocery store when they go out shopping. So first on the list here is a non-opioid analgesic. So we're going to talk about a couple of those. Acetaminophen, which is known, the brand name is known as Tylenol. Everybody's familiar with this drug. It's good to treat fever, mild to moderate somatic pain, osteoarthritis. It really doesn't help with inflammation. So rheumatoid arthritis and those types of patients generally don't get relief from Tylenol. I've listed some maximum dosages here. It's important you'll see this on the package insert. When you look at Tylenol, it's limited to 3 to 4 grams per day. So most of the time you'll see our elderly folks taking Tylenol, 650 milligrams 2 to 3 times a day. Tylenol, as you can see, or acetaminophen, is listed as a first-line treatment for persistent mild pain in older adults, and that's from the American Geriatric Society. I do talk about some of these non-opioid medications because what happened in the 1990s when we really felt that opioids were safe, lots of times that's where docs went first. So the practice guidelines should be changed, and our focus should be changed to look at when there is mild, persistent pain, we should go with a medication like acetaminophen first to make sure that we save those opioid analgesics for more chronic, severe pain. Another non-opioid class of medications, the oral non-steroidal anti-inflammatory drugs, or NSAIDs. Everybody's probably familiar with Aleve and Motrin and those types of products that you can buy over the counter. There are some prescription items of these products. Also, a drug called meloxicam is a prescription item that can be prescribed by a doctor. Most of these medications work very similar. They all work very similar, but most of them have an analgesic effect that can be replicated from one drug to the other. So traditionally, if you respond to one of these medications, you'll respond to another one of the medications within the same class. The challenge with this class of medications is its side effect profile, especially in the older population. And I'm going to go to the next slide just to kind of show you where these side effects happen. And most of us when we think of drugs like Motrin and Aleve, stuff you can buy over the counter, you really don't think a lot about some of the potential side effects. And these are pretty significant in our elderly population. So I've listed those here: confusion, kidney toxicity, fluid retention. One of the things that the non-steroidal anti-inflammatory drugs do is cause the body to retain fluid. And therefore, in our independent living and assisted living folks who are ambulatory and going to the grocery store and going to activities, they may be bothered by a persistent lower extremity edema or fluid retention that can increase their blood pressure and also precipitate things like heart failure, etc. Sounds kind of significant for a drug you can buy over the counter, right? And they are definitely drugs that can present challenges in our elderly folks or our seniors. GI toxicity, these medications do cause gastrointestinal bleeding or bleeding of the stomach, and lots of times we'll add a medication like a proton pump inhibitor like omeprazole to kind of help with reducing that GI risk and toxicity, because if a senior does develop a bleeding episode from a nonsteroidal, lots of times that is a challenge when they go to the hospital and have a lot of other problems that crop up after that. So those are some of the common side effects around these medications, and I think they're important to take into account. That they're an alternative in some cases to opioids because they do work very well in patients who have inflammatory type processes like rheumatoid arthritis, osteoarthritis, those types of things that they do decrease the inflammation and can result in decreased pain. However, as I've mentioned here, there are a lot of side effects that we need to be very careful about. The next slide talks about a medication that's been on the market for quite some time now, Tramadol, which from the data that my company has researched, Tramadol is used probably more than any other analgesic in our assisted living and independent living residents. And I do think that Tramadol has come into favor because of the issues of the facts of partly of the opioid issue, and then also this medication was not a controlled substance at one time. It is now a controlled substance. So very similar to the hydrocodones and the Tylenol with codeine type of products, this drug does require a prescription. It's indicated for moderate to moderately severe pain. It does not really have any acute advantage over opioids in acute pain, so it is a drug that lots of times we use from a mild to moderate chronic type of pain situation. Some side effects I've listed here: nausea, vomiting, generally well tolerated. The challenge with this medication is it does have some drug interactions, which from a pharmacist and a physician nursing standpoint, we do have to keep an eye out on these drug interactions because they can precipitate and look lots of times like behavioral episodes in our senior population. So once again, I'm telling you that these medications, albeit they're alternatives in some cases to the opioids, they have their challenges also. So Tramadol is a drug that's out there quite a bit. So let's shift gears for the last few minutes here and talk about the opioid medications and just talk about them briefly around what are some of the recommendations around using opioids for our folks who have chronic pain, and then also alternatives in certain situations to make sure that we are using the lowest possible dose and also make sure that we're using medications as appropriately as we can. So the CDC has come out with some guidelines on prescribing opioids in chronic pain, and these are some guidelines that were intended for primary care providers or people who are caring for people who have chronic pain along with the geriatric population. So they've defined chronic pain. I think we talked about it a little bit earlier in the presentation that, chronic pain typically lasts greater than 3 months past the time of the tissue injury or the tissue healing. One of our slides that we talked about earlier says in the geriatric population that chronic pain is generally concerted at about 6 months. So there are different interpretations on that, but I think it's important to remember that this is a chronic situation. The prescriber should look at the overall evidence based on the effectiveness and risk of long-term opioid therapy, and it should be low in quality per the grade criteria. And the grade criteria is actually the criteria that looks at evaluating medical literature and how these medications are effective for certain types of pain and certain types of other clinical chronic conditions. So when you use these medications, it should be at the lowest opportunity for risk in that resident to make sure that we're avoiding potential side effects and also potential problems with these medications. Determining when to initiate or continue opioids for chronic pain. The guideline also talks about opioid selection, dosage, duration, follow-up, and discontinuation. Yes, I did say discontinuation. There are certain situations, and we'll talk about a slide here in just a second, that we do as prescribers need to look at reevaluating that medication over a period of time. I think those of you that have been following the opioid crisis out there is noticing that this is becoming a standard of practice, is to provide lower doses, less frequent dosing, and shorter periods of time to make sure that the pain, one, is treated for the shortest period of time needed to cure that pain or either help control that pain, and then look at reevaluating the medication. Assessing the risk and addressing harms with opioid issue also naturally is a key factor. So just to kind of reiterate from the last slide, these are things that I think are important for us as people who are taking care of folks in assisted living and senior living communities when prescribing opioid medications. We want to look at making sure some of these factors are things that we've always known about the geriatric population, but we want to make sure that we're using these drugs appropriately. We should use immediate release opioids when starting medication. So in other words, use short-acting immediate release products, because lots of times our geriatric or senior population, when they get a medication that's either a long-acting or sustained release product, if they have side effects, that drug stays in their system a much longer period of time and can create problems down the road. When opioids are naturally start low and go slow, That's our mantra with dealing with the geriatric population with medications, is to go low and go slow. I would also add here that you need to go, though, also. So start low and go slow, but go. You've got to get that pain treated. You've got to make sure that we're effectively controlling that pain to prevent a lot of the stuff that we talked about earlier, where our seniors deal with sleep problems and depression and those types of things that can go along with undertreated pain. When opioids are needed for acute pain, prescribe no more than needed. As I mentioned, that's kind of the clinical practice guideline that's going forward, that large companies and large retail pharmacies are pushing for, to make sure that we only use for a certain period of time. As I mentioned, do not prescribe long-acting or extended release preparations for acute pain. Follow up and reevaluate the risk of harm, reduce or taper the dose, or discontinue it if needed. So I think one of the things that we sometimes forget about, and because of the nature of us being comfortable with these opioid products for a number of years, we oftentimes don't go back and reevaluate those medications. And that is an opportunity for us to reduce addiction and then also avoid some of the side effects that we're going to look at now. So this is kind of your opioids that we talked about as in the last couple slides and spoke about as far as appropriate use and et cetera. But I've listed some of them here: the immediate release products, the morphine immediate release, oxycodone immediate release, and then long-acting preparations. Long-acting morphine and opioid analgesics should be used for long-term management of chronic pain, as we mentioned, in acute situations or in situations where you're starting a resident on an opioid. We should not be using these long-acting preparations. So as you can see there, these products should be used appropriately when treating the current condition. Another class of medications that I think I've debated on touching base on this drug just during the talk, but I think it is an important one, albeit it is used most often in the nursing home skilled environment. There is an opportunity for us to see the drug in assisted living and independent living. That's the transdermal fentanyl patch, and many of you have seen this drug probably on the market. It's been on the market for years. Fentanyl is a potent narcotic. It is one of the narcotics that is creating a lot of the challenges out there with opioid overdoses because it is so potent, and it is a drug that commonly is the source of diversion and abuse amongst healthcare professionals and other people who abuse narcotics. I mention this drug just because when we're dealing with residents in assisted living and in independent living, I really don't think that there's a lot of opportunity for the use of this medication, because most residents in the setting of assisted living and independent living can take medications orally, and this drug really should be limited to a use in a resident who has difficulty swallowing long-acting medications, because fentanyl is a long-acting preparation, and they should be not able to take those medications. That's really one of its really only opportunities to be used, at least in my opinion, in the assisted living and independent living area. So if you do see this medication, there is an opportunity based on the clinical presentation of the resident to look at an alternative drug, because as you can see here, this medication, and let me give you a couple reasons why. When this drug shouldn't be used, as I mentioned, all other medications are oral. The problem with this medication in some situations is our seniors do have lean body mass and lots of times poor circulation, and this medication therefore can be absorbed at different rates based on different people. And if they're not used to taking narcotics or not been exposed to narcotics over a long period of time, they're much more susceptible to those narcotic side effects, which we're going to talk about in the next slide. So I think this is a drug that, like I said, I debated on putting it in the presentation, but I think it's important for all healthcare providers, especially when we're dealing with our senior population, to be aware of this medication because it does have challenges in the seniors. Now, there are certain folks patients that can or residents that can take this medication and tolerate it, but there are certain situations where an oral medication would be much better and much better for the resident. So let's talk about some side effects. And, these are the side effects that occur with these opioid medications. And as I've talked about through this whole presentation, I think it's one of those that we need to, in our senior population, we talk about opioid challenges. We're not dealing in most cases with overdose and those types of things. We're dealing with the side effects that they see here. And if you can see, there's a lot of them. The ones that are most common to our geriatric population are the mood changes and somnolence that these medications can cause, lethargy, drowsiness, which can lead to falls and other types of challenges, nausea and vomiting, decreased respiratory rate, constipation is a real challenge with these medications that our elderly population don't tolerate as well as younger populations. Tolerance is an issue with opioids. Larger doses required for the same amount of pain relief. That's why you start at the lowest dose and titrate upward, especially in a geriatric person, because as the larger doses are required, the side effects continue to increase and mount. There is dependence naturally with these types of medications. That's why they're controlled substances, which can lead to withdrawal symptoms, and abrupt discontinuation can lead to significant withdrawal. And that's an area when one of the challenges that we're dealing with these folks who are in assisted living and independent living who have been on these drugs for a long period of time, we've already seen situations where because of this opioid crisis in our country that some residents have taken upon themselves to try to get themselves off of their medication and done it too quickly and therefore caused potential problems with withdrawal. So that's where the healthcare provider community can get involved in helping them to remove that medication in a stepwise process, because just stopping it abruptly can really cause problems in these folks. I've got some considerations for common opioid side effects here. This is a nice slide, I think, because it talks about some of the key areas that we can look at and how to manage those. As I touched on just a few minutes ago, I picked 4 here, and constipation being the first one. I think anytime we start someone, a senior, on an opioid medication, we should start them on laxative also and make sure they have a bowel regimen in place, because that side effect can lead to really significant problems where someone could wind up in a hospital with an impaction or another type of problem with their gastrointestinal tract. And tolerance to this side effect does not occur. So constipation is, in the elderly population specifically, are going to be a narcotic issue that they're going to have to deal with. Respiratory depression, we've already talked about that. You can help avoid respiratory depression by starting a low dose and titrating very slowly. Nausea and vomiting, once again, this is lots of times the most common side effect that seniors experience with narcotics is nausea and vomiting. Women seem to be at higher risk for this. Need to look at their diet to make sure that we're avoiding certain types of food, because one of the things, as you know, can happen in somebody who is nauseated and vomiting is they don't get the food that they need. They can get dehydrated, and once again, that's another opportunity for one of our seniors to wind up in hospital outside of their community and outside of their assisted living facility. And then lastly, delirium. I always touch on this one because the narcotic analgesics, the opioids, do have significant cognitive side effects, especially in folks who have not been predisposed to them at any dose for a certain period. That's why we always use the lowest possible dose, but making sure that when these potential side effects of cognitive status changes occur, that we manage them accordingly. And that is by using the lowest possible dose and maybe having to manage those behaviors with other medications until the tolerance to the delirium develops. So just a couple, last slide here, and then we're going to open it up for a few questions. And as I mentioned at the beginning, I really do appreciate everybody's time and being on the call today. But just a couple of thoughts on how we can improve pain management and make sure that we are using medications to treat our seniors as effectively as possible, and then also naturally trying to avoid the common side effects of opioids, avoid addiction, and avoid those types of problems in our geriatric population also. Education to me is always a key. I think everybody who's on this call today, I hope, took away a couple things as far as ways that we might be able to interact with our residents and making sure that their pain is being treated appropriately, and also making sure that our staff understand what to look for and how to manage those types of problems. Monitoring for judicious use of pharmacological interventions. Here's the key about avoiding types of opioid issues and making sure that we're using opioids when they're needed as appropriate as possible. And as we touched on, go low and go slow, use the short-acting products initially, and if someone needs chronic therapy, then you can look at an extended release preparation. And I think it's always prudent to question transdermal fentanyl when patients or residents are able to take other types of medications orally. So those are some key areas where we can look at avoiding those opioid-type issues. And then we have to anticipate side effects. So the last thing you want to happen is a resident be put on an opioid analgesic and they not be on a bowel regimen and run into problems there and wind up in the hospital. Make sure that our staff understands that their breathing may become compromised or decreased because of these medications, and then naturally monitoring their level of cognition when these medications are started. And we're talking about the opioids here, but remember that drugs like Motrin, Tramadol, and even sometimes, some cases in the past we've seen with acetaminophen, do have cognitive side effects in our older population. So anytime there's a medication change, making sure that we monitor for that and look at the appropriateness of how that medication is being used. So just a couple conclusions, and we'll open it up. As we talked about earlier, untreated pain can result in a reduced quality of life. Following pain management standards can help overcome barriers, and properly making sure we characterize our pain and use those non-pharmacological interventions that we touched on earlier with physical therapy and non-physical therapy, non-pharmacological processes can really help serve as adjunctive therapies to using the medications. Because I think if we do use those non-pharmacological things, we may be able to use less medications, which as a pharmacist, believe me, I think less medications in our older senior population is one of the key things to making sure that they have a high quality of life and live for the longest period that they can. So with that, I'm going to turn it back over to Lois, and we're going to have a few questions, I hope, and we'll finish up here after that.
Thanks, Todd. Yeah, that was all very useful and interesting information. As Todd said, we'd like to take some questions from listeners now. If you have any questions for the speakers, please type them in, and we'll try to get to as many as we can. We do have some questions here. The first one, Todd, could you talk a little bit more about non-pharmacologic treatments for pain in residents?
Sure, I'd be glad to. I think as the slide indicated, I think there's definitely an opportunity for us, specifically with assisted living and independent living from a home care standpoint, to have our residents participate in things like physical therapy, strengthening exercises. It's an opportunity for our activity departments in those areas to get folks involved in exercise when they're able to, because we know that those types of strengthening, muscle building type of activities do help manage, especially those inflammation type pain processes like rheumatoid arthritis and those types of things. So I just think they're a key factor, and they also help when you have medications on board. Those practices do help add to the success of that medication. One of the things I always do encourage is we've talked a lot today about side effects of medications. I often see situations where we may have a resident who's on pain medication because of something that happened, an injury or something like that, and their dose of their pain medication is covering their pain, but it's making them lethargic to the point where they can't participate in physical therapy or other non-pharmacological interventions, that's a great opportunity in my mind to get the medical team involved, to assess the dose of that medication, to maybe back off on it a little bit to where that person could then participate in those non-pharmacological activities such as therapy and probably have a much more successful path down the road. So I hope that answered your question. I think there's a lot of things we could talk about on non-pharmacological things, but I think making sure you're looking at the key opportunities around the type of pain that you're dealing with and matching that to the non-pharmacological intervention, and then make sure that medications are not impairing the resident's ability to participate.
Okay, great. Another question we have is, what are some multimodal analgesic approaches you are seeing or you recommend?
So the question just kind of, one of the things we didn't get into in this presentation, because we want to focus on the opioid medications, is there are a lot of additional products out there that may be used for other indications, but also have some analgesic effects. And when the person asked about multimodal approaches, I'm thinking of using an antidepressant such as some of the antidepressants have analgesic effects that can be used synergistically with narcotic analgesics to help better control certain types of pain. We could spend another hour talking about neuropathic pain and pain associated with chronic damage from diabetes, et cetera. There's all different types of pain management processes around that. But we do use adjunctive therapies, and there are medications to help augment narcotics, which do allow us to reduce the dose of the narcotic analgesic, and those are opportunities that a lot of healthcare providers, prescribers, physicians are leaning on now, because we do want to make sure that we're using those opioids at the lowest possible effective dose. So you will see a lot more out there soon on multifactorial approaches to pain, the key factor being starting with the non-pharmacologicals, and then when you have a pharmacological agent, looking at the potential to augment that therapy with another medication. I know that's contrary to what I talked about earlier today about lowering medications, but then there are times when you need to, if these drugs work together, it can be very beneficial for the resident. Likewise, if the drugs don't work together, like a drug interaction, and cause adverse events, that's something we need to aggressively look at discontinuing or adjusting that medication. Thank you.
Another question we had was, when an independent living or assisted living community isn't directly involved in medication management for residents, what kinds of things can they do to try to prevent opioid addiction?
Yeah, I think that's a great question. And I think, when you're not directly involved in the medication therapy or medication management, one of the key factors to me is making sure that our staff, the people that interact with those folks, are aware of, and look at potential signs of addiction, look and monitor for potential side effects of medications, et cetera. But one of the factors we talked about in non-pharmacological things was education. A lot of the folks who are in your facilities now probably were started on these medications in the 90s when we thought that they were okay. And they've been taking them for a long period of time. As we talked about earlier, educating the resident, educating their family on the potential hazards, because as these people age and get older, those side effects are going to become more pronounced, and they're going to be more at risk for them. So as I think we talked about at the beginning, looking at ways to reduce the risk of our residents developing adverse events or serious consequences is, I think, a key factor that we can play a role in their overall management, even if we're not managing their medications. So education, I think, is a key, and that's not just to your staff. I probably didn't mention this appropriately when I said it, but it's your staff, it's the resident themselves, it's their family members, and making sure that if they want to go down that path of getting off of that medication, as I mentioned earlier, it should be done appropriately. It should be done in a controlled environment, and it should be done in a methodical way to where we avoid withdrawal, et cetera. Good question.
Great. And then another one, are there any clinical guidelines you are aware of that address pain management and depression comorbidity?
Yeah, the CDC guidelines, the ones that I spoke of earlier, does have some things in there about looking at other specific treatments with concomitant conditions, and also the National Institute of Health, NIH recommendations do look at comorbidities of pain and how they should be treated. Because, as I mentioned earlier, when you think about it, some of the antidepressants do have analgesic effects. So if you use an antidepressant that has some analgesic effects, you may be able to use a drug for two things and be able to reduce a dose of an opioid or something like that. So yes, there are some key factors involved in managing comorbidities with pain and other conditions for that matter that are out there in those published guidelines, because there are many factors that you need to take into consideration based on the resident's comorbidities and how those conditions are affected by the medications that you're going to be prescribing.
Okay, great. And I think this is our last question. If your question wasn't answered during the webinar, we'll try to get back to you afterwards to make sure that you have the information that you're seeking. Well, this is a two-part question about Tramadol. Is it okay to crush it is part one. And the second one, verification on something a listener thought they saw in your slide, that it's okay for 75 and older people, residents, as long as the dosage doesn't exceed 300 milligrams a day?
So yes, the Tramadol comes as two different preparations. It comes as an immediate release and a long-acting preparation. The long-acting preparation should not be crushed. The shorter-acting preparations, in my understanding, they can be crushed. Just to elaborate on Tramadol just for a second, as the slide indicated, that dosing came out of the package insert and is what's recommended based on that information. I think one of the things to take into account with Tramadol is it is a product that, as I mentioned earlier, does have some drug interactions. The specific one that is most concerning is the one with the serotonin reuptake inhibitors. That's the antidepressants that we know as Celexa, Lexapro, Zoloft, those types of medications. And because Tramadol and those drugs work on serotonin, the serotonin levels in the brain can be increased to the point where they look like what's called serotonin syndrome, which lots of times in older folks looks like delirium or dementia. And the reason I went down that path to explain that is I've seen it at much lower doses than that 300 milligrams. So I would be cautious with that medication at any dose, because we really don't know how those drug interactions are going to present themselves between each individual resident. So especially when those other drugs are on board, I think it's important to take those dosing guidelines and kind of look at them with a grain of salt. Now, if you've got a patient who that's the only medication they're on and not on any other serotonin-type medications, then that's probably okay as a dose. But, you know, with all the other medications these residents are taking, I would be very, very cautious with that dosing. Great question.
Okay, great. Well, thanks again, Todd. We really appreciate the time you spent with everyone today to give them this important information on the topic. And to everyone listening, I'd like to say we hope you've enjoyed today's webcast. Remember that this session will be available shortly to listen to again online. So if you would like to listen to it again, or you think a colleague might benefit from listening to it, please write down the address you see on your screen, www.mcknightsseniorliving.com/December5 webinar. You also can use the link you received via your email address to access the webinar again, or find the link on our website, mcknightseniorliving.com, under the Events tab at the top of the page. Please remember that accrediting bodies dictate that the CE credit will be given only to people who attended this live broadcast. We did have some questions about the availability of slides, and we'll try to respond to those after the webinar as well. And again, if your question was not answered, we'll try to get those answers to you as well. We'd like to give special thanks to Todd King for taking the time for us today to frame this important issue in an understandable way for senior living providers. We'd also like to thank our sponsor, Omnicare, a CVS Health company. Remember, you can visit www.omnicare.com. And thanks to all of you for listening today. The questions you had were really outstanding. I'm sure your colleagues benefited from hearing those as well. Once again, thank you for tuning in. This is Lois Bowers from McKnight Senior Living.